Hemo terminology is the next topic. So the key terms to write down and know for exams. The first one is leukocytes, or WBCs, those white blood cells. So the memory trick, think L for leukocytes, is L, they like to clean and defend the body against infection, like viruses and bacteria. The next key term is erythrocytes, our red blood cells, RBCs. So we have hemoglobin, which is HGB. These are the oxygen carriers on RBCs. So the memory trick is look at the O's. For hemoglobin, think O2 carriers. Now the next one is erythropoietin, EPO. This is a hormone produced by the kidneys with small amounts made by the liver. It basically tells the bone marrow to create red blood cells, those RBCs, which carry around oxygen from the lungs to the rest of the body. So the memory trick, think erythropoietin throws requests to make RBCs. The next term is thrombocytes. These are the platelets. So think platelets plug cuts to stop bleeding. And the next key term is really difficult to pronounce. So hematopoiesis, or hematopoiesis, is the formation of blood cells and occurs inside the bone marrow. The key term there is bone marrow. So just remember that all the blood cells are created inside the bone. Now the next term is hemostasis, fancy words for blood clotting. Now this is a process to prevent and stop bleeding, meaning to keep the blood within a damaged blood vessel. So the opposite of hemostasis is hemorrhage, basically active bleeding. So hemostasis involves coagulation, meaning blood clotting, or the blood changing from a liquid to a gel to form a clot, and eventually stop the bleeding. Now there is a very complex coagulation cascade that can make your eyes turn in circles. But to keep it very simple, just think, clot formation starts with prothrombin. Then it leads to thrombin, and then the fibrin mesh where the clot is formed, with the help of platelets. And for clot destruction, when a clot is dissolved, we see clot retraction, and eventually plasmin breaks the clot down. All right, that wraps it up. Thank you so much for watching. Don't forget to take your Anemia is our next big topic. In general, this is a condition where the body lacks enough RBCs, those red blood cells, to carry oxygen around the body to perfuse the tissues, typically resulting from blood loss, like surgeries or excessive menstruation, or even from taking immunosuppressants, which suppresses the bone marrow where RBCs are made, but more commonly from the lack of iron, B12, and other building blocks to build RBCs. Clients who are anemic will present with tiredness and fatigue, with shortness of breath, dizziness, and even pale skin, called pallor. All these signs and symptoms are due to the low RBCs, which are supposed to carry oxygen on their hemoglobin attachments to help perfuse the body. So a big NCLEX tip here. Hemoglobin is the lab to know, so write it down. Normal values are over 12. Now it becomes bad when it's 8 to 9. And anything less than 7 sends your patient to heaven. These are must-know key numbers here, so write it out and know it by heart. Now the main types of anemia to know for exams are iron deficiency anemia, sickle cell anemia, and pernicious anemia. Now for a little side note for your pathophysiology exams. There are 2 other types of anemia that you should be familiar with for your patho course. So number 4 here is aplastic anemia, where we see impairment in the bone marrow, which makes blood cells. And pancytopenia, where we have low RBCs, low WBCs, and low platelets. Now all the blood cells will be low here due to the bone marrow impairment. Now number 5 is hemolytic anemia, where we see destruction of RBCs, those red blood cells. They basically burst inside the body due to incompatibility with blood transfusions, known as antigen-antibody reactions, like from giving a client the wrong type of blood and the body rejects it. Now this is very deadly, but we cover all 4 types of blood transfusion reactions in the blood transfusion video. But really the most tested on the NCLEX are the top 2 here. So let's cover these first. Iron deficiency anemia is where the body lacks iron, which is a critical building block to help make RBCs, our red blood cells. Now, it's the most common type of anemia globally. So Kaplan mentions, the nurse understands which is the most common type of anemia, iron deficiency anemia. Now, it's caused by a diet low in iron-rich foods. So the key terms to know for exams is any diet low in meat, fish, and poultry. These contain rich sources of iron according to the NCLEX. Now, fruits and green leafy vegetables do have iron too, but not as much as the meat-based products listed above. Now, another big cause is gastric bypass surgery, as iron is not adequately absorbed in the new, smaller stomach. Another known cause is during pregnancy. The fetus stores iron and it depletes the mother's iron storages, typically during the first trimester or during the second half of pregnancy. Now, pica is a very interesting cause. You mean Pikachu? No, not him. Pica is a very serious compulsive disorder where clients consume non-nutritional items like cornstarch, chalk, dirt, paper, and other items, typically occurring in pregnant women. So obviously this will lead to nutritional deficiencies, mainly iron deficiency, leading to anemia. So these clients will usually present with low hematocrit and low hemoglobin levels. Huge NCLEX tip, I would write that down. So low H&H with clients with pica. 70% of students get this wrong. So once again, think low H&H with pica Pikachu, or just pica. Okay, now for some other causes that may show up on your pathophysiology exams. So low serum B12. Now this B vitamin is one of the main building blocks to build RBCs, those red blood cells. Another cause is hypochlorhydria, where the stomach has low stomach acid. Now this is considered one of the most important causative factors, as gastric acid is very vitally important for iron absorption, as the stomach cannot convert iron within food into an absorbable form. And the last big cause here is gastric atrophy or atrophy, atrophic gastritis. This is the chronic inflammation of the gastric mucosa of the stomach lining, leading to a loss of gastric cells and eventually replacing them with scar tissue, resulting in the inability of the stomach to absorb iron and other nutrients. Now for infants and children, they often develop iron deficiency anemia from the following risk factors. Number 1 is premature birth. Number 2 is insufficient oral intake or delayed introduction of solid foods. Now a big one and a huge NCLEX tip is number 3, excessive intake of milk. Again, write it down. Over 24 ounces of milk per day. Now preterm infants who are exclusively bottle fed with breast milk, as it contains low iron, are typically recommended to take iron fortified formulas. Now a huge NCLEX tip here is the vegan diet, so be sure to write these key points down. Vegan diets exclude all animal products like dairy and meat. So number 1, fortified breads and cereals are recommended. And we always pair, number 2, high iron foods with high vitamin C, as it helps the iron to absorb. And number 3, calcium and vitamin D is recommended to supplement the lack of nutrition from the dairy. So write those 3 key points down for vegan diets. They love to come up on Select All That Apply questions as it applies to iron deficiency anemia. Now in terms of diagnostics, as mentioned before, the big NCLEX tip is knowing the hemoglobin levels. So once again, normally it's above 12. Now it's bad between 8 and 9, and less than 7 sends your patient to heaven. Remember, you must know these key numbers here, so write it out and know it by heart. As stated before, clients who are pregnant are expected to have low hemoglobin, less than 11. But it's very bad if we dip below that 9, so always report to the HCP immediately. Remember, anything less than 9 is bad, but less than 7 sends your patient to heaven. Now for the signs and symptoms, just make it super simple and think about the patho here. We have low RBCs, meaning we have low hemoglobin, resulting in low oxygen signs and symptoms. So we get fatigue with dyspnea, that shortness of breath, as well as dizziness and even paled skin called pallor. But the top 3 to know is dyspnea, pallor, and tachycardia. Now Hesse mentions, when assessing the patient's integumentary system, which dermatological manifestation may indicate anemia. Pallor, yes, that pale skin. So just watch out for that key term, pallor. Now, other key signs to note for your pathophysiology course. GI manifestations, I'd be sure to write this down. Stomatitis, where the clients get inflammation of the mouth and lips, as well as glossitis, the inflammation of the tongue. So low levels of iron actually lead to low levels of myoglobin, a substance inside the blood that plays a significant role in the health of all muscles inside the body, especially in the tongue. Now switching gears to sickle cell anemia. This is an inherited group of disorders that causes the RBCs to have a distorted shape, going from a nice round plump shape to very skinny sucked in sickle cell shape. Normally the RBCs have a lifespan of 4 months and carry oxygen around the body for adequate perfusion. But in sickle cell anemia, the lifespan is less than 3 weeks. They can't carry adequate oxygen to perfuse the body and get clogged inside tiny blood vessels, blocking or occluding the blood supply to the extremities and vital organs, which causes ischemia, that lack of oxygen to the body tissues. And this causes extreme pain during a sickle cell crisis. Now, all of this is called a vaso-occlusive crisis. The more pain, the more occlusion of the vessels. So for signs and symptoms, during a crisis, it depends on the organ involved. If a client has one-sided arm weakness or unilateral weakness, then one should suspect a stroke, a complication of sickle cells getting stuck and blocking oxygen supply to the brain. Now, swelling of the feet and hands, known as dactylitis, is also common due to sickle cells blocking the blood supply to the extremities. This is often the first sign in infants with sickle cell disease. Now, a big NCLEX tip to write down. Any words like new or sudden typically mean a priority on the NCLEX. So, new onset of paralysis of the extremities, or even sudden inability to be aroused. This indicates a critical client. So watch out for words like new or sudden, since these typically mean a priority client and a rapid response team needs to be called, since it could indicate a vaso-occlusive crisis. Now Kaplan mentions, a client experiencing a vaso-occlusive crisis, the nurse determines care is appropriate if which observation is made. The client receives regular neurological assessments. Yes, this is critical, since a stroke is a big risk. Now for other complications, acute splenic sequestration crisis occurs when a high number of sickle cells get trapped in the spleen, leading to splenomegaly. Fancy words for a big mega spleen. This is a life-threatening emergency, since most patients with sickle cell anemia have small spleens due to the recurrent ischemic episodes, that low oxygen supply. It can lead to deadly low blood pressure and is associated with hypovolemic shock, that severely low blood pressure. So on physical exam, one will find a rapidly enlarged spleen. So remember, think of a big old mega spleen with splenomegaly and low blood pressure. So these two key signs you must report to the HCP immediately. Now for pernicious anemia. This was the third most tested anemia. Clients with pernicious anemia cannot absorb B12, which is a vital building block to create RBCs. This happens because clients lack intrinsic factor in the GI tract, which helps the body to absorb and take in this B12. So Hesse mentions, which factor results from pernicious anemia? The absence of intrinsic factor secreted by the gastric mucosa. So the memory trick. Just think of Gollum from Lord of the Rings, who rubs his hands together near his stomach and always says, precious, precious. So just rub your hands near your stomach and just say pernicious anemia or precious anemia. They kind of sound the same, and since the hands are near the stomach, it helps you remember that the stomach is not absorbing the B12. Now the signs and symptoms include glossitis, which is a huge exam tip, so write this down. Glossitis is an inflamed, red, smooth tongue. This came up multiple times on various question banks. Now we also see extreme weakness as well as jaundice, that pale yellow skin. So Kaplan mentions clinical manifestations of pernicious anemia, glossitis, a smooth red tongue. And Hesse mentions the nurse is caring for a patient who reports extreme weakness and glossitis. The nurse identifies pale yellow skin. Which type of anemia does the nurse anticipate in the patient? Pernicious anemia. All right, that wraps it up. Thank you so much for watching. Don't forget to take your Now for DIC. The full name is disseminated intravascular coagulation. This is a serious disorder in which the proteins that control blood clotting become overactive, causing many blood clots to form all over the body. These thrombi, or blood clots, block small blood vessels, causing organs to infarct and not function properly due to the lack of perfusion, or basically the lack of oxygen. Now, the second big event in this condition, eventually the body uses up all the platelets and clotting factors, resulting in the body having no ability to stop bleeding. Therefore, we see bleeding everywhere, all over the body, commonly seen right beneath the skin, inside the nose and mouth, and even deep inside the body. Complications may include organ failure. So the patho goes in this order. Number 1, overreactive clotting, basically thrombi and infarct of the organs. Then it proceeds to number 2, depletion of all platelets and clotting factors for normal clotting. And lastly, major bleeding all over the body. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study. Now for hemophilia. This is an inherited bleeding disorder in which the blood does not clot normally, increasing the risk of excessive bleeding after any type of small injury, say from a paper cut or even a fall on the ground. So hemophilia A, we lack the clotting factor 8, which helps the blood to clot. And in hemophilia B, we lack the clotting factor 9. So Hesse mentions, a nurse is caring for a patient diagnosed with hemophilia A. The nurse knows which type of hemophilia is caused by an absence of which clotting factor. 8. Now, as far as signs and symptoms, we just have excessive bleeding, as you know. So we see pain, bruising, and petechiae, the little red bumps under the skin, and ineffective tissue perfusion, as well as joint stiffness and even lack of mobility. So Hesse mentions, a nurse is caring for a patient with hemophilia. Which concerns would be expected on the nursing care plan? Select all that apply. Pain, anxiety, deficit of fluid volume, and ineffective tissue perfusion. Yes, think about the low clotting factors here for hemophilia. Now for a little side note on hemophilia A. This is caused by an X-linked recessive gene that's passed from mother to son. And for diagnostics, blood coagulation tests are used to see how long it takes for the blood to form a clot. Now, 2 main tests are used for hemophilia A and B. The first is a prolonged APTT, activated partial thromboplastin time. Normally, it's between 11 and 12.5 seconds. And we see a normal PT, that's normally between 30 to 40 seconds. This is a prothrombin time. Now you're probably asking yourself, why is the PT normal? Well, it's normal since these conditions are caused by defects in clotting factor 8 and 9 in the coagulation cascade, which PT does not measure those clotting factors specifically. All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share. Leukemia is a type of cancer that affects the blood cells and bone marrow. You see, bone marrow is responsible for making blood cells like WBCs, RBCs, and platelets. But in leukemia, we have an overproduction of white blood cells that crowd out the production of normal cells, leading to low RBCs and low platelets. So let the name help you here. Leukemia Just think leuc for leukocyte, that WBC, and emia for blood. Too many WBCs that crowd out the production of other blood cells. Now, the main types of leukemia, we have acute and chronic. So acute is more common with pediatrics, and chronic is more common with older age. The four main types include AML, CML, ALL, and CLL. Now, the NCLEX doesn't really cover this directly. Okay, now specifically for your pathophysiology class, please be sure to write this down. It's very important. So acute leukemia, we see immature, non-functional WBCs, those white blood cells. So think acute is abrupt onset, very common in children. And for chronic leukemias, we see mature cells with reduced function. So this one is a slower onset, known as insidious, and proceeds gradually. So we commonly see it in older adults. Now, in terms of labs, we have high WBCs, but they are very immature and too young to fight infection. So we call them baby WBCs that crowd out the production of RBCs and platelets. So naturally, we see a low H&H, that low hemoglobin and hematocrit, and low platelets, which leads to higher risks for bleeding. Now, the signs and symptoms include frequent infections because the WBCs are too immature, and remember, too young to fight infection. We also see fatigue and an unsteady gait, as well as pale, called pallor. This is from anemia, that low H&H. So just think we have less oxygen carriers and less perfusion to the brain, skin, and muscles, looking very anemic. And we have bruising, petechiae, and easy bleeding from the low platelets, as well as weight loss and anorexia, and even bone pain from the bone marrow being overcrowded with an overproduction of WBCs. So ATI mentions a 7-year-old with acute lymphoblastic leukemia who is being admitted for evaluation of fever. To which of the following rooms should the nurse assign the client? A private room in order to prevent transmission of infection from others. Yes, we want to protect this patient from getting other infections. Very low immune system from those immature WBCs. Now, a second question, a nurse is assessing a child who has leukemia. Which of the following findings should the nurse expect? Select all that apply. So we have anorexia, petechiae on the extremities, and even an unsteady gait. And the third question, a child who has leukemia has a platelet count of 40,000. Oh man. Remember, anything less than 50 gets very risky. Which of the following precautions should the nurse initiate? Bleeding. So remember, anything less than 50 is very risky. Big time bleed risk. Now, in terms of diagnostics, we can do a bone marrow biopsy, typically taken from the posterior iliac crest, basically on the hip bone here. So Hesse mentions, a nurse is preparing a patient for a bone marrow biopsy, knows which site will most likely be used. Posterior iliac crest. Now, in terms of the treatments, we use radiation and chemotherapy to kill everything off, the good guys and the bad guys too. And very rarely we use a stem cell transplant, like hitting the restart button to reboot the entire system for bone marrow. Alright, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate, and even your instructor. See you guys in the next videos. Now for polycythemia, we have two types. Polycythemia vera is a type of blood cancer. It causes the bone marrow to make too many red blood cells, those RBCs, which causes sort of a major traffic jam within the blood vessels, making the blood very thick and slowing blood flow, resulting in blood clots all over the body. So please write this down. We see an increase in RBCs. We also see low erythropoietin levels. Basically that hormone from the kidneys that tells the bone marrow to produce RBCs. Now the cause is very distinct. We have cancer here, also called a neoplasm and a neoplastic disorder, meaning overgrowth of cells, and in this case, overproduction of RBCs. Now the second polycythemia is secondary polycythemia,
We see the same increase in RBCs, but this one is very different in that it's caused by hypoxemia, that low oxygen in the blood. Now, it's very different here, so let's break down the patho. With low oxygen in the blood, that hypoxia, the body says, oh snap, I better make more oxygen carriers. So loads of RBCs are made to compensate for this low oxygen. But instead of perfusing the body, the extra RBCs cause a traffic jam within the blood vessels. This thick, viscous blood can easily clog tiny little blood vessels and form deadly blood clots, specifically the tiny blood vessels inside the brain, causing a deadly stroke, a CVA, a cerebral vascular accident. So this is why we must report any extreme high hemoglobin or hematocrit level. So for diagnostics, increased RBCs, those red blood cells, but really the big one here is increased H&H. We must report this to the HCP, the healthcare provider. So an increase in hemoglobin and hematocrit. We're talking an extreme increase here, like 3 times the level. We also see hypercellular bone marrow from the bones producing too many RBCs, and also hyperuricemia, basically excess uric acid inside the blood due to a high turnover of RBCs, those red blood cells, which results in a higher than normal uric acid production. Now, in terms of manifestations, always think about the patho first. Think of the traffic jam of RBCs clogging up all the blood vessels all over the body. Naturally, this will cause a backup of blood flow, right? Leading to increased blood pressure. Also, hepatomegaly, that big mega liver, from the backup of all these RBCs. We also see a big mega spleen called splenomegaly, a big spleen, as well as sluggish blood flow and even cardiac hypertrophy, a big heart with really thick, overinflated heart muscles. Now, this is from the heart trying its hardest to pump against that thick, viscous blood, as well as headaches and visual problems from that slow blood flow to the brain and eyes. And it could even indicate a thrombosis, or basically a clot, which leads to organ infarctions. So a CVA is that clot in the brain, a cerebral vascular accident. An MI is a myocardial infarction, a clot in the heart. A PE is a pulmonary emboli, a clot in the lungs. And a DVT is a deep vein thrombosis, a clot in the deep veins. Basically, clots everywhere.
All right, that wraps it up. Thank you so much for watching. Don't forget to take your quiz and download the study guides. And also feel free to share the love, share with a classmate and even your